Hello, everyone, and thank you for joining us on our AORN Town Hall with our special guest, the AAAHC. Today is Thursday, July 30th, and my name is Carrie Lynn Johnson, Senior Manager of Chapter and State Relations for AORN. All attendees have been muted, but your feedback is very important to us. During the town hall, please submit questions or comments in the Q&A box below. All registrants will receive a link to the recorded town hall on Friday, and they can also find it on our homepage on the red tab that reads AORN COVID-19 Clinical Support. To view this presentation with the PowerPoint and presenter, please follow the instructions listed here. You will see a Zoom side-by-side mode when you click on View Options, and then the presenter will appear on the left and videos will appear on the right. To adjust the size of each side, hover your mouse over the boundary between the presentation, and you can be able to drag that line over and change the size of your screen. The outcome is listed here. Everyone will receive 1 contact hour for this webinar today. Please go to this URL to receive your contact hour, and we will have this listed in the recording as well. Now I would like to introduce Linda Groh, AORN CEO and Executive Director. Linda?
Good afternoon, everyone, and welcome to this town hall. We have a very special guest today, the Association of Ambulatory Healthcare, the AAAHC as we know them. They were formed in 1979, and they are a leader in healthcare accreditation with over 6,000 facilities being accredited by them. They accredit several organizations, among which are ambulatory surgery centers, office-based surgery facilities, and endoscopy centers. AAAHC, just like AORN, shares a commitment to safe patient care and advocates for the provision of high-quality healthcare through the development and adoption of nationally recognized standards. It was directly related to these common goals that we invited AAAHC to partner with us today. Our first speaker today is Jan Klein-Hesselbling, who is the Chief Quality Officer of Lincoln Surgical Hospital and associated entities. As COQ, she oversees the leadership of health information technology, laboratory services, quality services, and the regulatory compliance departments. Jan has been a surveyor for AAAHC since 2008 and is the immediate past president of AAAHC Institute for Quality Improvement. Jan, welcome to the town hall.
Thank you, Linda. Thanks everybody for joining us. I'm very excited to be here. We have some information to share about AAAHC that I think you're all going to really enjoy and find very beneficial. So we're going to start by asking a polling question. And the question that we have for today is, how many people are currently AAAHC accredited? And for those who are AAAHC accredited, how many or who of you is Medicare deemed status? Why don't we go ahead and get started while we're waiting for that answer, because we have a lot of information to cover today and I don't want you to miss any of the important information that we have to share. So we're going to talk a little bit about version 41, the AAAHC Handbook that is coming out. The AAAHC Handbook is now called version 41 and it has been reorganized, renumbered without significant changes in requirement. The number of elements of compliance don't exceed 7. Some of the language has been deleted because there were some redundancies and there was some editing done for clarity or applicability. The sub-elements of compliance are no longer rated individually, but the elements must be present for the standard to be rated yes. Past editions were identified by calendar year, but this year AAAHC has made the decision to switch to version numbers, and that will separate the release of new revised standards from that time frame and provide more flexibility. I think this is a really exciting change moving us forward. So for those of you who are Medicare deemed status, you're going to see this new and improved scoring. At the standards level, it's a fully compliant or a non-compliant. The new Medicare Handbook is not yet available, but it's currently being developed and will be available soon. When CMS, the requirement for the fully and non, okay, I've got to back up here because it's hard for me to explain this without being confusing. So the requirement at the standard level and the element level now are yes or no. So you just are now like either fully compliant or non-compliant. It's a yes or no answer. No longer do we have the option for partially compliant. Now you'll see how these elements that are yes or no then roll up to a rating depending on the number of compliant elements and applicable elements. You can see on the bottom here where 2 out of 3 elements are present, 1 or all elements are present, and that rolls up to that particular standard compliance rating. When standards are a AAAHC requirement and there are only CMS requirements at the element level, those CMS requirements are still a yes, no, and the ratings will roll up to that aggregate compliance rating as we just kind of covered a little bit. The sub-elements, as you can see under number 3, are no longer rated separately. They must all be present in order for that answer to be yes. Okay, so that's just a very high level description of how the physical standards handbook has changed. Now let's talk a little bit about what some of the upcoming standard changes are, because this is where I think you're really going to get some valuable information. So we're going to get started on that. If you want a complete rundown of all the changes, you can reference the new handbook on page 215 to 221, the non-Medicare handbook. And we also encourage you to check out our webinar that's available on the AAAHC website. So we're going to cover some of these important standard changes right now. One of the major changes in the surgical chapter is the division of what used to be standard 10.1.m, and it has been changed into 2 separate standards. And this really makes sense because while procedures verification has always been required, there are some situations in which you might not need to verify a site or mark a site. For example, an endoscopy procedure. In fact, the 2018 standard specifically exempts endoscopy procedures from site marking. So now standard 10.1N addresses the verification of the procedure. Then we move on to standard 10.1.0, and this standard specifically addresses the site marking. Now there's some pretty exciting changes in this particular standard, this is the new standard for site marking, and it is different in a few ways. So first, it does require a written policy. Now, you might already have a written policy at your organization for site marking, and I just want you to keep in mind that even when the standards vary a little bit, if you put a more stringent policy in place, the surveyors are going to hold you to that policy. So you're going to want to review your policies on site marking when you get looking at your policies. I was going to say when you get back to your organizations, but I guess you're probably not, you're probably there or close by. So it's different in a few ways. So first, it does require site marking. Secondly, the policy needs to contain a definition for the surgical team. So you're going to have to define who is on that surgical team. And this is really important because at element 4, you'll see that we have changed the requirement for who must mark the site. And now you are allowed to have a member of the surgical team to do so as long as that person fits within the definition of who was present during that timeout. I know it's different from what we're used to, right? But this change does align with the CMS interpretive guidelines that allow the site to be marked by another member of the surgical team. The interpretive guidelines are not prescriptive regarding what members of the team that needs to be, who can mark that site, but our standard now requires that you define who that might be in your policy. So again, back to that policy discussion. If your current policy requires that the site be marked by the person conducting the procedure, you might want to update that policy, or you may decide that that's the practice that you want to have in place and retain that policy. But then if that is the case, then the surveyors will be looking to your current policy to rate this standard. So let's move into pharmaceutical services and the changes that have occurred there. The 2018 standard contained a requirement for look-alike, sound-alike, and high-alert medications, and the standard required that these lists were present in the facility. What we've learned from organizations was there were at times, there was some misinterpretation of that standard, and some organizations interpreted it to mean that as long as they downloaded the list from, say, the Institute for Safe Medication Practices, if they just downloaded that entire list and posted it, that was sufficient, and that met the intent of the standard. But that was not actually the intent of the standard. The intent is to know whether or not you have any of those medications at your facility. So this new standard requires ongoing monitoring of your medication inventory so that you know if any look-alike, sound-alike, or high-alert medications are present, or if any get added to your medication inventory. So that's why it has to be an ongoing monitoring process, so that if something new comes into the organization that meets the definition, you would know that that is there and that would be on your list. You also need to have procedures in place to prevent errors. If you do have those kind of medications in your family, then either one or both in your family, I'm sorry, it's the end of the day. In your facility, or maybe in your family, then either one or both of these standards will apply to you. But if your monitoring activities show that you do not have any of these medications, the standards don't apply. However, you do need to do that continuous monitoring to ensure that that does not change. On a side note, the look-alike, sound-alike medications have now been changed. The terminology has now been changed to confused drug names. That's the new terminology that's being used by the Institute. So if you go to the Institute for Safe Medication Practices, it also just says, instead of saying look-alike, sound-alike medications, it says list of confused names. I looked it up today. It was kind of interesting. Now the other piece of this, when you are putting your procedures in place to prevent those errors from the confused drug names, I just think that sounds so funny. Like, how do you even define that? It just sounds like the drugs themselves are confused. The tall boy lettering or the tall man lettering is still an important aspect. And I'm sure all of you are familiar with the tall man lettering, but just in case you're not, the tall man lettering is writing part of a drug name in uppercase letters to help differentiate look-alike, sound-alike medications. So let's move on to pathology and medical laboratory services and some of the changes that we're going to see there. Now in Chapter 12, the first 5 standards have been revised for a few reasons. First, we need to recognize that there are multiple types of CLIA certifications, and some of those, well, not some of those, all of those are the Certificate of Waiver, which many of you may have, the Certificate for Provider Performed Microscopic Procedures, and Certificate of Registration, Compliance, or Accreditation. This does not mean that you are required as an ASC to have one of these certifications. As is currently the case, you need to have whatever is appropriate for the type of laboratory services that you provide. Currently, though, if your facility is located in New York or Washington State, then you would apply for your laboratory certificate or license through your state rather than directly through CMS. That's just sort of a side note for you. And another thing to know is that some states require both CLIA and a state certification. I don't have a list of those states handy, so if you're not sure, you need to check your state regulations. And now all of these different types of CLIA certifications and situations are now addressed by standards 12A through 12E. The handbook also contains some helpful notes at these standards that will help you clarify when these would apply. If you have a CLIA waiver only and you only conduct waive tests, then the other elements of standard 12.1 will not apply to you. But if you do have a type of CLIA certification and are conducting moderate or high complexity testing, you now, for AAAHC, need to demonstrate that you are following manufacturer's instructions for calibrating equipment and for conducting validation tests on new equipment. The first new standard addresses proficiency testing. And we have seen some comments on the ASCA blog that indicate that not everyone knows what proficiency testing is. So I'm just going to explain it briefly. We have a moderately complex lab in our organization, so I'm pretty familiar with this proficiency testing. Briefly, it's a process for verifying the accuracy and reliability of the testing that you do, including the competency of your testing personnel. And it can vary from analyzer to analyzer. So if you do have a moderate or high complexity lab and you're bringing in a new analyzer, it's really important for you to make sure that you know what is required for that analyzer and for that proficiency testing. We've recently started doing some cardiac procedures. We just opened a cath lab. And so the hemocron that we brought on site has some pretty stringent guidelines for that proficiency and competency testing. The standard does require proficiency testing only if someone is already requiring that you do it. For example, for us, our moderately complex CLIA certification requires that we perform this. So this also would apply though to your own policies. So back to that policy discussion, if you have in your policy that you require proficiency testing, then as a surveyor, we're going to look for that proficiency testing that you have described in your policy. So to determine whether or not this standard would apply to you, just check the requirements for your certification type. And if you need to know more about proficiency testing, here's a website that can get you started on that. The final change to Chapter 12 is at Standard 12M, and this one's fairly simple. This is regardless of the level of testing that you conduct. So it doesn't matter what your certification states, whatever testing that you are doing, you must make sure that the items that you are using have been approved for the FDA for your certification type. So you'll need to just verify that if you decide to add something new, that level of testing is approved for your certification type. So we've talked a little bit about the changes for the version 41 handbook, and you will see on this slide there is a website that you can go on and it will help you download that handbook. It is AAAHC's and our 1095 philosophy that we want to make sure that we are continuously providing you with information that's going to help you achieve and maintain your AAAHC accreditation. So this document, this handbook, is complimentary for all accredited organizations. So if you have any questions or need any help, just contact AAAHC. So when are these changes going to take effect? How do I know if this really is going to impact me and my organization? Well, generally speaking, the effective date of version 41 is November 1st, 2020. If your accreditation expiration date is on or after November 1st, 2020, you will be surveyed against this set of standards, even if your survey takes place before November 1st. So if your expiration date is on or after November 1st, these are the standards you're going to need to use. As a reminder, even if your next survey is not due until early 2021, the effective date for compliance with the version 41 standards is November 1st, 2020. I think the questions can be submitted through the Q&A. And at this time, I would like to introduce Cheryl Pipestone. Cheryl has over 39 years experience in nursing, including 4 years as a lieutenant in the Nurse Corps for the US Navy. Cheryl is currently the Clinical Director, Accreditation Services at AAAHC. Among other responsibilities, she oversees complaint management and adverse event reporting process at AAAHC and provides clinical expertise and knowledge across the organizations. So I will turn it over to Cheryl.
Thank you, Jan. So today, thank you to AORN for having us. We're delighted to be here. Did you have another polling question, Jan? Here?
No, I did not here. Okay.
So I'll just dive right in then. So I'd like to talk about the next slide for me then, please. I'd like to talk about the top deficiencies. Every year, AAAHC compiles data about the frequently cited standards from the last year, and we put this in a quality roadmap. And this data is organized by type of organization, common standard deficiencies for both Medicare deemed and non-Medicare facilities. And they're also compared by office-based surgery settings. And we also put in several surveyor comments in this document so that it gives facilities an idea on how to correct standards that are not met, so organizations know where to start when correcting these issues. On this first slide, this is for non-Medicare deemed standards. These are the most commonly cited deficiencies from the year of 2019. The first one that's the highest, most cited deficiency is in our clinical records chapter, and this has to do with reports, histories and physicals, lab reports, etc., not being acknowledged by physicians or signed off on. This becomes important, for example, when a critical result is in the is placed in the chart and the reviewing physician is unaware, resulting in the patient possibly suffering less than a good outcome. As you can see, this is a frequently cited standard and has been something that organizations have struggled with. Suggestions for compliance could be to have a mechanism in place for staff to notify physicians of all new report results placed in the chart for the patient. This can be something as simple as a checkbox if paper charts are used, or a field to review if electronic records are used. Next to that is standard 22G, which is a standard related to peer review. This standard is part of our credentialing chapter. You can see that this standard is cited about 13% of the time. This standard reflects the requirement to have peer references as part of peer review in the re-credentialing process. This goes hand in hand with the next standard that's part of privileging chapter. That's cited about 10% of the time. Peer review is part of a function of the medical staff. The medical staff should be involved in the development of the peer review criteria and should be based on clinical guidelines. Other things to monitor for peer review are patient transfers, adverse events, patient complaints, and any noted trend in peer review such as infection rates or other monitors. This information should then be included with recredentialing information for physicians for reconsideration in their recredentialing application. 5.1c has to do with our quality improvement chapter. This particular standard outlines the 10 steps related to our QI studies. As you can see, some organizations struggle with this. There are several tools available on how to do this process, including a toolkit and a breakout session at our AAAHC seminar that goes over this process. It's also included in our version 41 manual under the tools section. And the last cited part of this slide is drills, and this is found in our facilities chapter. The problem with this one is that drills are not scenario based. It's frequently cited because people do their drills and they'll do a drill that's not scenario based. The other part of that, a drill should be that it's evaluated. And if you find an issue with your drill that it's not successful, then you need to fix it and then implement the fix immediately. For example, if you do a fire drill and you try to evacuate your patients and you decide to evacuate them on, like you're going to evacuate a sedated patient on a gurney, and you realize some of your gurneys might not fit through all of your doorways, then that is something you would include immediately in your evacuation plan to say, we can't evacuate sedated patients on gurneys through these doorways. We'll have to figure out a different way to do that, and how you're going to update that in your plan. Next slide, please. These are our most frequently cited Medicare deemed standards. There's a little more of these and a little more frequently cited. The first one that we're going to talk about is, again, in our privileging section, standard 22D. This is related to carrying out specific privileges requested by the medical staff. What's important to note here is physicians should request privileges that are able to be done in a facility. For example, a facility should have an approved procedure list, which then physicians should select privileges that they are trained and qualified to do, and that are approved by the governing body. For example, if you have a physician who is quite capable of doing open heart surgery, but the surgery center is not capable of having open heart surgery done at the facility because they don't have that long of stay at the surgery center, they don't have the equipment, the staff's not trained, etc., then that's not a privilege that the physician should request. So physicians who are trained to do more but not necessarily should be done in a facility, they should request the privileges that can be done realistically at the facility. Next to that is infection control privilege. I'm sorry, an infection control standard. This has to do with the infection control plan not frequently citing national guidelines and being based on national guidelines as part of your plan. Most commonly, people cite things that their plan is based on national guidelines such as the CDC, AORN. If you're a GI center, it's going to be something like SGNA or ASCA, to name a few. The point is, the infection control plan must be based on nationally recognized guidelines and be part of the written plan. Going on to 9S, this is safe environment for anesthesia. You will see this standard cited frequently when multi-dose vials are not used correctly, such as propofol. You'll also see this cited when multi-dose vials our narcotics are found in anesthesia areas and no one is present in the OR. This means you can tighten up your narcotic policy and you can have surveillance or increase your surveillance for safe injection practices. 11J also has to do with safe injection practices. This is a chronic problem in some facilities. Surveyors note that multi-dose vials are used incorrectly, that the septums are not wiped off on vials before their needles are inserted, and that medications are not labeled appropriately. One suggestion to improve this is to institute the One and Only campaign from the CDC and include these as monitors in your infection control plan. 4E3 has to do with medication reconciliation. A lot of people don't understand medication reconciliation, and medication reconciliation actually has 3 parts to it. One is to ascertain the patient's current home medications and the last time they took those medications. The next part is to know if there's any new medications that the physician has ordered as a result of whatever they had done to them in the facility that day. And then the last part of that is that they leave with orders if they're to continue or renew their home medications or discontinue any of those medications. And they leave with a current list of whatever medications they're supposed to have. And that there's a copy of that in their patient record, and the patient leaves with a copy. So it's a whole circle of medication reconciliation. 11B1 has to do with pharmaceuticals, that drugs are prepared and administered according to established policies, and this standard is typically cited along with other safe injection practice issues. 7.1c again goes back to infection control issues. This has to do again with safe injection practices, and this one has also to do with hand hygiene surveillance or other adequate monitors to track infection control issues. 11M, interesting, goes back to the very issue that Jan was already talking about, having to do with confused drug meds. I like the confused thing. I can remember being confused. Drug names. This was the look-alike, sound-alike drugs, but this has to do with facilities not having a policy in place to recognize that. 10.1H also has to do with medication reconciliation standard and patients not leaving the facility with their list to do with that. And 8.2D2 goes back to the drills that we've already talked about. Also, this has to do with scenario-based drills and not being done with a scenario or being evaluated. Next slide. So this has to do, this slide is office-based surgery citations. You'll see some of the very same issues we've already talked about, only found in office-based surgeries. 2.2G is the peer review issue, very similar. 8.1 has to do with drills being not scenario-based. 7.2E is worth talking about because this has to do with expiration dates on medications, and not just medications, but anything that really has an expiration date. People not tracking this, or people not looking for it, or even keeping track of it. We look for those, and we will look through crash carts, and we'll look through cabinets, and we'll find things that are expired, and surveyors will do that, and you know, you should be doing that in your facilities as well. 5.1A, this is a big standard because the very first standard in Chapter 5 is that you will have a written quality assessment. You'll have a written plan. And so you have to have a written plan. And I'm kind of surprised that this is cited 10% of the time. And it has to be approved by your governing body annually. 5.1D has to talk about benchmarking, external benchmarking, and there's a lot of people struggle trying to find external benchmarking, but there's a lot of organizations that do external benchmarking. If you can't find a group that's similar to you that wants to do external benchmarking, there's always professional organizations that do external benchmarking, and there's, you know, AAAHC does studies twice a year. There's a lot of places, ASCA does external benchmarking. So there's a lot of places you can go that that can do those. Let's see, I think I lost my place here. 10.1Q has to do with the lack of discharge instructions and patients leaving without having any written discharge instructions. 11F again is having to do with sound alike and look alike high alert medications. And 7.1B and 7.1C are very similar, and they're both related to infection control issues. But 7.1C, I would like to point out, is that infection control program has to be under the direction of a qualified healthcare professional with training and competence in infection control. This doesn't mean that they have to be certified in infection control, but they have to have training in infection control. So, and they have to be delegated and it has to be in writing. So some people miss that one and don't get that taken care of. So now we move on to observations during COVID. So AAAHC already has started data collection for our quality roadmap in 2020. And so here are some of the things we're already noticing. You'll see some recurring themes here. And, you know, as a result of COVID, we're pretty interested in seeing how people are doing. Infection prevention and control, the data collection since March 20 has shown us that there's been a slight increase with citations regarding formal risk assessments for infection control, which is understandable in the age of COVID. Organizations are struggling every day with keeping up with new guidelines from the CDC and how to stay compliance with the PPE standards in the face of shortages. AAAHC resources can be found on the new AAAHC website, where several webinars and FAQs are available for your view. Anesthesia services. Interestingly enough, this has to do with malignant hypothermia agents and malignant hypothermia drills. If you have anything in your facility that can trigger malignant hypothermia, such as succinyl choline, then we expect you to have all of the things that make you compliant with malignant hypothermia. And that includes the medications such as dantrolene or Ryanodex, the cart that has all of the equipment that you're going to need for it, that you've had a drill, that you have the posters, that you have just all of that you need. Safety, there's a whole bunch of things roll up here under safety. Some of it has already been discussed, such as medication errors. Important things to add to that included are your recall policy. A lot of people make the mistake that if they have a recall policy, they only need to have one that is recalled meds. But recall policy has more to it than that. You should have one that includes food. If you provide patients food, if you do implants, your recall policy needs to address implants and anything else that might affect a patient. So you need to look at your recall policy and make sure it includes all of those things that might impact your patient. The other thing to remember under safety is that all of your employees and your physicians too should have some sort of safety training within 30 days of coming on board or being hired. Under emergency preparedness, again, you know, we're seeing some this is hugely important in the time of COVID, as it's just one of the emergencies to plan for. However, this pandemic involves the entire community and should be considered in the facility risk assessment, as well as the infection control risk assessment. And we have seen, you know, I've read a lot of reports, and we are seeing people planning that way for COVID, and some people are doing a really good job with that. I might say. So not just being cited for it, but also doing a really good job with it. And pharmaceutical services, this information has been covered, but you can see people are still struggling with it a little bit. And so also clinical records, people are still, so far in 2020, people are still not improving very much with having physicians acknowledging lab reports or clinical signing off on different documents in the clinical records. And the same thing with pathology results. That's still a continuing issue. In governance, on a formal application for initial medical or dental staff privileges, let's see, we're finding it's still an issue with privileging for anesthesia. What we're seeing there is that if you have a organization that has CRNAs or RNs who are giving moderate sedation, you have to have somebody who has supervisory privileges to supervise those people, and we're not seeing that on privileges. So that is an issue that we're still seeing cited. As far as administration goes, again, it's the orientation and training not being completed within 30 days. With peer review, we've talked about this. It's important now with COVID. This can be a new added element as far as aspects of care, something for your physicians that can be considered. And risk management, it's the same education piece as far as training and safety training offered to the staff. So especially if you change up your PPE, you need to train your staff on any new PPE that you're getting. If it changes, or if you're, fit testing them and you have a new fit testing going on. And with that, I have a polling question. We'd like to know, are you COVID-19 testing per emergency use authorization? And after you answer that question, I'm going to hand it back to Jan.
Thank you, Cheryl. Gosh, that was a significant amount of information that people can now really absorb, and I think it's going to be great information for them to sort of focus their own reviews at organizations. I think you'll all find it really helpful as you look at your organizations and try to sort of hone in on areas that are commonly missed. So I did notice when we got our numbers back from our polling that we do have several attendees, or quite a few attendees, that are not AAAHC accredited. So I do want to just take a step back here and make sure that I'm clear about the two types of handbooks that AAAHC has. So we have the AAAHC handbook that is for deemed status or Medicare status organizations. If you're getting your deemed status Medicare certification and accreditation, that is a different standards book than just the regular AAAHC standards book. Their version 41, the version 41 non-Medicare standards book is available now, and that's the one I was referring to that you can download from the website right now. The Medicare deemed status handbook is still under development and is not quite ready yet, so that will be coming soon, and we will certainly let you know when that's available. About 42% of people are COVID testing. That's very impressive. Tests are challenging to even get your hands on right now. So I believe I have a polling question as well now as we move forward. And the question that I have is, at what capacity is your organization currently operating? Are you open 100%? Are you going at 75, 50, 25%? We just want to sort of get a sense of where people are at as far as reopening for services. Cheryl covered some information on COVID, and there is additional information if you would like to check out our complimentary webinar and get a detailed look at the standard implications. That is available on the AAAHC website under COVID-19 resources. Interesting. It looks like many of you are right back to work. Okay. Well, this is a journey, right? As we enter into sort of our new normal, and AAAHC is absolutely aware that organizations have experienced a wide range of scenarios that they've had to deal with as this COVID-19 pandemic has evolved. Many surgical procedural facilities have continued to operate at full capacity, which I think we could see by our poll. Some organizations have had to close for at least a period of time. Some have reduced capacity, or even maybe had to furlough some staff during this slower time. And many found themselves navigating new or offering different services, maybe some increased telemedicine, patient care, or some may have even transformed or transitioned into a hospital during this time. We all have had to adapt, and we're all going to continue to do what we need to do to ensure that safe and effective patient care. This is really a time for us to get really passionate about taking every precaution on how we do deliver patient care and what we can do to be thoughtful about how COVID is changing the way we approach things. We really also need to consider the staff and really double down on our compassion related to staff. As we know, they all are also dealing with their own personal and professional challenges. We have to remember how difficult this is also for our teams. There's a long journey ahead. I think it's going to take us a while to get back to the new normal. And that might be very different than it was a few months ago, or maybe even different from what it is today. And AAAHC, we just want to make sure that you know that we are with you every step of the way, and our goal is to be here to help. So let's look at standard implications, and those are really dependent on your situation. Really, the bottom line is whether standards are waived or not. That's going to depend on your situation throughout COVID. If your organization is conducting full on-site patient care operations throughout, you will be expected to be in full compliance with all of the patient safety requirements, with the exception of those that have been waived by the government, such as medication expirations, PPE shortages, and the use of cloth masks. If your doors were closed or you had to alter or reduce functionality and capacity, you may not have been able to meet some of the requirements. And at AAAHC, we're developing a checklist specific to the standards that will provide helpful guidance on considerations you should bear in mind as you move your organization forward. We are not introducing new standard changes on this checklist. The checklist addresses standards which may have been waived. This means that during the period in which an organization was closed, or if you had to operate at a reduced capacity, or even if you altered functionality, there may just be some valid reasons why those standards couldn't be met. And for these standards, you would not be expected to double down on the next quarter. The standard is actually waived for that specific period of time. If you didn't do any drills for the entire year and you were open 50% of the time, that would not be acceptable. Organizations are expected to resume compliance as you are resuming operations. For example, the requirement for quarterly drill would be really difficult to do if you didn't have any people in the organization that quarter. Now, if we talk about deferred would be a gap in the application of your policies during the period in which you were not seeing patients at full operational status. So this would mean that during the period that you were closed or that you were at reduced capacity, if you were in a situation that prevented you from meeting those requirements, you will have to catch up on the requirements, but that you will not be deficient for the gap that was incurred while you were not doing normal operations. So let's talk about safety for just a quick minute. If it's a safety issue, that must be addressed before you could resume on-site patient care. For example, testing equipment, crash carts. It's okay if there's a gap in testing when you weren't open, but it does have to fully be up to standards before you can resume patient care. And deferred also, if it's an administrative issue, it must be caught up within that 30 days. So resuming your data collection, the things that maybe drive your quality, patient safety, and studies. So there's no free pass, sorry, for the entire 3 years. You don't get to just like cite COVID. I try to use COVID for everything I don't get done. I can't work out because of COVID, can't do all kinds of things because of COVID. So when it is time for your survey and your surveyor comes in, they will understand the deferred and the waived. They will be asking you for your plan moving forward on how you're going to get into compliance if it's a deferred situation. We're going to expect that you have been taking action and that you do have a plan so that you can make sure that you are caught up on those. We will ask to see that. You should just know that ahead of time. We will be asking to see that. So here's a picture of the checklist that we're working on. And this is the exact same checklist that the surveyors are going to be using. So that will be very helpful for you. Thank you for your time today. I've enjoyed chatting with all of you. And now it is my pleasure to introduce Noelle Adachi. Noelle is the president and CEO of AAAHC. She has focused most of her 33-year career on driving programs and leading organizations to improve quality, compliance, and patient access to quality care. For the past 2 years, Noelle has led the transformation of AAAHC by building a more sustainable platform for growth, including reshaping the governance model, redesigning its core IT system, and strengthening its headquarters while driving an internal and external culture shift to the 1095 strong that I mentioned earlier. And that is our quality every day. So welcome, Noelle.
Thank you, Jan, and thank you both, Jan and Cheryl, for sharing your frontline expertise as both surveyors and practitioners with all of our audience today from the AORN membership. I'd also like to thank Gail and the AORN team for inviting AAAHC to participate in today's town hall meeting. In March, AAAHC dramatically shifted our processes in response to the COVID-19 pandemic. We moved to a remote work structure, postponed or canceled hundreds of accreditation surveys, and dramatically increased our communication with our client organizations through webinars, our website, and email communications. It's amazing to think that it's only been about 4 months. I feel like during that time I've lived many more years, and Jan referred to everything having the excuse of COVID-19. Well, I am definitely carrying the COVID-15. All of us have been personally and professionally impacted by the COVID pandemic. We've had to be flexible and adapt and deal with uncertainty on an ongoing basis. But during this period, AAAHC's commitment to improving quality through accreditation has remained steadfast. In today's environment, this means that we are carefully monitoring changes in regulations and executive orders in the national and local level. We're developing new tools to help our client organizations maintain compliance with these evolving rules and other limitations as demonstrated with the checklist. And we are heightening our communications to help guide your focus on priority areas and deal with circumstances that we've never had to deal with before, we've never had to face before. And through that, we are committed to collaborating with organizations like AORN who share a common mission to ensure quality care is delivered to patients. So in addition to ramping up our surveys and navigating this dynamic state level situation with shutdowns and quarantine restrictions, we have been looking to and investing in the future. I wanted to share with you just a few of the areas that we are pursuing as we lean into this COVID-19 new normal. We've been investing heavily in design and development of our new accreditation management system that will drive client engagement throughout that 1,095 days of the accreditation cycle. Our designs give intense consideration to how you and your facilities will interact with AAAHC and how we can efficiently and accurately provide you with the accreditation information you need to continue driving compliance. At this point for our accreditation management system, we're looking at a mid-year 2021 full launch. Our standards development committee has been quite busy. They're looking at potential standards revisions driven by COVID-19. Beyond the obvious infection prevention and control areas, we are also looking at whether telemedicine is becoming more of a standard of care delivery mechanism versus a specialty service. Now, I don't know if any of you have experienced telemedicine in your personal lives, but I have, and I assure you there is a significant variability among practitioners. New factors need to be considered, and practitioners need training in how to be effective in this new delivery mechanism. Among other system, process, and program expansions and improvements, we are looking at how elements of the survey can be virtualized. We do not believe that the virtual survey can replace the expertise that our surveyors bring to the on-site visit, but there may be elements of the survey process that lend themselves to virtual interaction. There's a lot to think about before we proceed with that. To operationalize virtualization of components of the survey while delivering on our commitment to patients that facilities accredited by AAAHC are consistently and continuously adhering to high quality practices of care delivery and safety. You know, we don't know what the future is going to hold, that's for certain. However, we do know that the need for ensuring quality patient care has never been more important. My sincere thank you to each of you, one for participating in continuous learning in today's session, but also, and more importantly, because of what you do on a daily basis to fulfill that commitment to ensuring good care to your patients. Again, I'd like to thank AORN for keeping us sharp and the opportunity to collaborate with you in this program today. And with that, I will turn it back to Linda. Thank you.
Thank you, Noelle. We are so delighted to have the opportunity to have you join us today. You've taken us on a short journey through the AAAHC standards and also given us some bits of knowledge as well as some pearls that I know will help everyone on their journey to a successful criteria for meeting your accreditation standards. I do want to take a couple minutes just to remind everyone that AORN has a number of products that might be of assistance as you focus on your journeys. We have a prep for ASC infection prevention certification. We have an ASC infection prevention online course, an ASC administrator training online program. And coming up very soon, we have the prep for the certification for ambulatory surgery nurses. CCI has announced, as you know, that they will be developing and have developed and actually have a test that will be implemented in September for certification for ambulatory surgery nursing. So this is so exciting. We've worked with them for a number of years on looking at the job reviews, and it has resulted in a certification. So watch our website. There will be information on the certification, the prep for the certification exam that will be coming in August, and that exam will be given the month of September. And that's going to be considered to be the beta opportunity. So take the opportunity to take that test, and if you pass it, you will be a certified ambulatory surgery nurse. So again, I want to say thank you. Our time has come to an end, and I want to thank Jan, Noelle, and Cheryl for your support of AORN's ASC members and for sharing your knowledge and engaging with AORN on this town hall. Good evening, everyone. Have a pleasant evening.